lung, which means that must be the air outside pushing the lung in, right, collapsing the lung. So if we take a look here at this X-ray, like this lateral decubitus X-ray, do we see where the lung markings stop and where the border of the air begins? Where is it? Where is it? Where?
Keep going up.
Up.
Keep going up. There.
Right there. Good, right here. So you see this line right there? So below this line, you can see all of these fuzzy lung markings. Above the line, all you see are ribs, but you no longer have that fuzziness. And there's this nice, clear delineation right there, this nice, clear line separating the two. So that is a sign for pneumothorax. Like we said, pneumothorax may be treated with a chest tube, which is literally a tube stuck here in the chest between the ribs. Yes, Jay?
Are the terms decubitus and cross-table synonymous?
Are the terms decubitus and cross-table synonymous? Yes, you can think of them as synonymous because a D-cube just tells you that you have a horizontal beam with the patient on the table. Okay. Some more examples of pneumothorax. Okay. Where's the pneumothorax here in this left image? In the right lung here?
The left lung.
In the left lung? Or is this the left lung and is this the right lung?
No.
Patient's left is marked.
This side is the left. The one where you're pointing.
This is the left?
Yes.
Are you sure?
You know the marker is there.
Good, the marker's here. Right. Just check your marker. So yes, this is the left lung. And as you can see, on the right side, you've got all these nice, beautiful lung markings. On the left side, it's all air, right? Except for this section right here. So there is that collapsed lung. Okay.
So their first lobe collapsed then, on the left side?
So the entire lung has collapsed. Okay, over here, do we see the pneumothorax?
There's a distinct line marking on the left lung side.
On the left side again, very good.
Right.
So over here you see the lung markings all the way out to the ribs. On this side, right, you have this line right here. So lung here, air here, right? So lung, air. What is this thing right here? You see this weird artifact?
So these are those
Like lead?
like leads around that.
Not a lead. What did you say, Reagan?
You said some kind of tube.
Some kind of tube.
Drainage tubes.
What kind of tube do you think would be on the side with the pneumothorax?
Drainage tubes.
Chest tube.
Chest tube.
Chest tube. Very good. So this is how we treat a pneumothorax, with a chest tube. It's about, I want to say it's about this thick.
Oh. Where's the tube?
The tube is right here. It's this tube coming in right here. Right, it's got this little bit of like metal here that makes it easier to show up on X-ray. But you can see the other end of the edge of the tube right there as well. So it's this plastic tube. They basically cut a incision here on the side of the patient, shove the tube in, they try and get it to the location of the pneumothorax, and then you take a chest X-ray to make sure it's in the correct location. Yes, Mansi?
So how do you differentiate between the pneumothorax and atelectasis?
So atelectasis will not have air on the outside of the lung. If we go back to the pictures of atelectasis, you notice that it's white outside the lungs rather than, right? So it's whiter here rather than black, right? White. It's white. Right? So atelectasis is not due to air collapsing the lung. So you do not see air outside the lung here. So great question. Very good question. A few more pictures of pneumothorax. Okay. Any idea where the pneumothorax is here?
Oh,
On top.
Near the apices?
both
Near the
sides.
apices, yes, very good. So you see the lung markings down here?
Mhm.
Lung markings down here, right? But then you get up here in this region and you don't see that fuzziness anymore, right? You get up here to this apice and you don't see that fuzziness anymore. Yes.
What's wrong with their left costophrenic angle?
Left costophrenic angle is blunted, right? So it's no longer sharp, it is rounded. So what could be the cause of that?
There was we talked about something that did that, right?
Right, there are several things that can do this. Atelectasis can cause this, pleural effusion can cause this. Pneumothorax, I don't remember if that's one of the things. It may also cause that as well. But yes, if you see blunting of the costophrenic angles, that is a sign that there's some sort of pathology.
So where is that again?
So the pneumothorax is up top here.
On both the lungs. So in both the lungs.
Both the
Oh, I
lungs.
seen both. 'Cause I was looking for the line, so I seen the
So
line, so
that's
that's
how
why I
it's
said
thinking.
both. So
So,
I don't know, I could be- I
so
could
the
be just-
pneumothorax could
But I
cause
wasn't looking at that.
the left costophrenic angle because it looks like the left side is more,
The line.
like there's more air on that one.
So on the left side, we can kind of see this right here. It seems to stop here. I don't know if it comes all the way down here, but could it cause that?
The pressure wouldn't it?
So that I am not sure. I would need to go back and double check that. But I want to say it's possible, but I'll have to double check to be sure.
Professor, I need to
Yes.
understand why is that portion in pneumothorax? I can't see it on the left side.
You can't see it on the left side? Okay,
On
so
the right side, sir.
on the right side. So on the right side, you see all of this fuzz.
Yes.
You see all this fuzz. You see all this fuzz. Do you see fuzz up here?
No.
No. Fuzz here. Fuzz here. No. So where there's no fuzziness, where there are no lung markings, that is a sign that there's pneumothorax, right? Compare that to something like this, right? So this lung is normal. You see the fuzz go all the way up to the
I
apices,
see.
correct?
Thank you, sir.
Right? Or so the fact that we're missing lung markings on both sides tells us we do have pneumothorax.
And those calcified spots are normal?
Here, tough to say.
Because a lot of other patients have the same sort of spots.
Right, it's tough to say. I can't tell you if that's normal or not.
Okay.
I unfortunately am not trained that well. Okay, over here, also have another picture of a pneumothorax. Do you see where it is in this right image?
Yeah, I see the arrow. It's telling us.
There's an arrow here.
Yeah, so that's, yeah.
Okay. Yeah, there's an arrow here. That's true.
You did
It's
that?
on both sides.
Okay, but yes, it is on both sides once again. Right, so we see fuzziness, but then up top here,
Yeah, I did not
right,
see that.
no fuzziness.
Yeah.
Up top here, no fuzziness.
You basically did it like
Right, so sometimes the pneumothorax can be kind of small like this. Sometimes the pneumothorax can be massive like this or like this. It depends on just how much air was able to make it into that pleural space.
So for those severe cases,
Yes.
they would drain out that excess air and then try and reinflate the lung, or would they let it happen naturally?
So yes, the lung will reinflate naturally. The only reason why the lung isn't inflating is because there's more pressure outside the lung than inside. We remove the pressure by draining the air, and the lung will be able to function just like normal again. Okay, next up we have pulmonary edema. Okay. Edema, what does this tell you? Good. That's right, we're dealing with fluid. Okay, so if you see edema, you know that you're going to be dealing with fluid somewhere. Here, right, we're dealing with fluid inside the lungs. Pulmonary edema. So, because we are looking at the lungs, once again, PA and lateral chest x-rays. Because we are dealing with fluid, comparing fluid to air, which one is more radiopaque?
Fluid is.
Fluid is more radiopaque. Does everyone agree?
No, air.
Air is more radiopaque.
So air is thicker and dense as
Air is radiolucent. I'm getting a lot of conflicting messages
Wait a
here.
minute, say the question again.
Pop quiz, let's get it.
Okay, so comparing fluid to air,
Okay.
which one of the two is more radiopaque? Is fluid more radiopaque or is air more radiopaque?
Fluid is more
Fluid.
radiopaque.
Fluid is more radiopaque. Fluid absorbs or blocks X-rays better than air does. But remember, opaque means that it blocks, it doesn't let things through, right? Lucid means it does let things through. So radiopaque is going to be radiodense. It's going to show up white on the X-ray, right? Less radiopaque, more radiolucent. It's less radiodense, it shows up blacker on the X-ray. So yes, fluid is more radiopaque compared to air. Yes?
So in your PowerPoint 3, slide 3, you're saying radiolucent, sorry, you said radiopaque is more dense.
Correct.
But in the PowerPoint, it says radiolucent, increased radiographic density under radiolucent,
See.
not under radiopaque.
This one here?
Yeah.
So, radiopaque, right? So, metal, most radiopaque, then bone, water kind of in the middle. As we go up here, right now it becomes more radiolucent, right? Fat, more radiolucent, air, most radiolucent. Okay? The more radiopaque it is, the more radiodense it is, right? So, as we come down this way towards the radiopaque items, those items are more and more radiodense. Right? As we go up this way, as we head towards the radiolucent items, they become less and less radiodense.
In the parentheses,
It
it
says-
says increased radiographic density.
Is that talking about the
Yes.
image itself?
So, what does radiographic density mean in that case? So, in that case, we're talking about how many X-rays are going to be reaching the image, right? The more X-rays that reach the image, right, the denser that is, right? Denseness is about how much stuff there is, correct? Right? If something's dense, there's a lot of it. If something's not dense, there's not very much of it.
So that's talking about what makes it to the IR?
So in this case, radiographic density is what makes it to the IR. Okay. So radio density here, what we're talking about is the object has a lot of mass, a lot of matter in it. It blocks the X-rays from going through. So that is our radio density. But if we're talking about the density of the image, the density of our radiograph, our radiographic density, right? The areas that got a lot of X-rays are going to be considered dense. The areas that got very few X-rays are going to be considered not dense. So the black areas, the places which let X-rays through, are radiographically dense because air is not radiodense. It's so instead of radiopaque, air is radiolucent. Does that make sense?
Yeah.
Right, so it is two different terms. We have radio density versus radiographic density. Right? They are describing two different things. Radio density refers to the actual object being X-rayed. Are we X-raying air? Are we X-raying fat? Are we X-raying water or bone or metal, right? That is radio density. How thick that stuff is, how well it absorbs X-rays. Compare that to radiographic density, which is purely about how the image looks. And what causes the image to look the way it does? The number of X-rays which reached your receptor. So radiographic density is about the density of X-rays which have gone through the anatomy and reached the receptor. Does that make sense?
So in one X-ray taken on an image or on one chest, the amount of X-ray should be the same, right?
What do you mean by that?
If I'm taking an X-ray of the chest, sir, the X-ray thrown on the chest is the same on each part, right?
No.
It's not sun. It
So-
depends on the how opaque or how lucent it is.
Okay,
That-
so let me try and give an example here. Let's say that okay, so I've got long, right? I've got long, and I've got spine here, right? So just imagine that we're looking at the patient from above. Does that make sense? So we're looking at this patient from above. Over here, this is our IR, right? Our image receptor. Okay, and now we are going to start shooting X-rays across this way, right? We're shooting X-rays this way towards our patient. Okay, good so far? So, as the X-rays come through, so we've got some X-rays, got X-rays coming like this, X-rays coming like this, X-rays coming like this, 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 this. All right, so far so good? All right, so we've got X-rays reaching our patient, correct? And once they reach our patient, one of three things can happen. What are those three possibilities?
Either they be absorbed.
Okay, so absorptions, scatter, transmission. Yes, very good. So we have absorption, scatter, and transmission. So, lung. What is inside the lung? Air. So, is the lung radio dense? Is the lung dense? Is it filled with stuff?
No.
Or is it very loose? Is there not very much stuff in there?
It's loose. Air is that lucent, that's what
Right.
it is.
Air is loose, right?
Right.
It's easy to move through air, right? There's stuff floating in the air, but molecules, oxygen, carbon dioxide, right? But it's super spread out. That's why we can move through it, right? I can't move through the table
Right.
because the table is all super packed together, right? The atoms in here are squished, they're solid, right? They're dense. So air is not very dense. In terms of X-rays, air doesn't absorb X-rays very well, right? So it's not radio dense, it is radio lucent, which means most of these X-rays here will pass through the lungs. So X-rays pass through the lungs pretty easy, right? Maybe some of them will get absorbed partly, right? Maybe not all of them will pass through the lungs, but most of them will. Okay. So far, so good? Right, so maybe a few didn't get all the way through, but most of them will go through the lungs because the lungs, the air is not radio dense. On the other hand, here we have the spine. Spine is bone, right? Bone is pretty solid. So spine is radio dense, right? And because it's radio dense, we also call that radio what? Radio opaque. Great. So spine is very good at absorbing X-ray, right? So X-rays come in and they get absorbed here to spine and they don't go through. So now we take a look over here, right? This is soft tissue, right? Like fat or muscle or bone. So soft tissue compared to air, is soft tissue more dense or less dense?
More dense.
More dense. Okay, because there's more stuff inside the soft tissue. But compared to bone, is soft tissue more dense or less dense?
Less.
Less dense, right? It's not as compact as bone is. So soft tissue is somewhere in between, right? It's not fully radiopaque, it's not fully radiolucent, it's somewhere in the middle. Oops. Okay, so now we have our X-rays that have reached the IR. So if we take a look at where they reach the IR, we've got here, 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 Okay. So now we have a certain number of X-rays which have reached here. Right? What is the most dense location of X-rays? Where do you see the most X-rays located? Right, so you see them here at the bottom, you see them here at the top, right? You maybe see a few here, right? But mostly the X-rays are going to be concentrated in, right, in this region, which was where the lungs were. So on the image is going to show the density of X-rays, how many X-rays reached the IR. So the radiographic density is not here where the body is. Radiographic density is here, talking about the IR instead. Okay, so high area of radiographic density, high area of radiographic density, low area of radiographic density. So radio density and the density on the X-ray, they are inverse, they're opposite. Right? The more radio dense something is, the more X-rays it absorbs, and so the fewer X-rays can reach the IR, and so the lower the density becomes in that location. Okay, so higher density absorbs more X-rays. IR now has lower density because fewer X-rays reached it. Does that make sense? Mm-hmm. Right. So radio density versus radiographic density.
So when, so for example, if the lungs are radiolucent, that means that the radio density is really high.
Don't type it out.
Okay, so right. So if we're talking about the lungs, okay, so lungs are filled with air. So the radio density of the lungs is how?
High.
Do they let X-rays through? So do the X-rays absorb it? Do the lungs absorb X-rays very well?
No.
They do not. Right, the X-rays pass through. So why did they pass through? It's because it's radiolucent. So this is not radio dense. It is not blocked X-rays. Radio density is about the ability to block X-rays. And radiographic density then is going to be the color on your final image, if that helps.
Yeah, there you go. I think you should do that more often.
Yes, on the image, the darker the color, the greater the radiographic density, not radio density.
I gotta write that down. Say it slower.
So maybe I shouldn't say color on the image. Maybe I should say X-rays that reached you.
No, that makes sense though to me, like the color.
The density that goes through the anatomy and reach the IR, right?
Yeah, X-rays that reach the
I wrote it down when I went to sleep. I was like, what?
Instead of image, let me just say IR. to be more okay. So radio density describes the ability of a tissue to block X-rays. Bone, high ability to block X-rays, so it's radio dense. Air, poor ability to block X-rays, it is not radio dense.
You alright?
You alright, Mr. Phung? You got sleepy too, huh?
What do you mean?
Because you just froze. Sometimes you know how you be.
No, I freeze because I'm checking your reactions.
Oh!
Like, how are they feeling?
I'm feeling good about this.
Feeling good.
I know I had sleepy.
Forgot it, but this doesn't bother me. I don't know. I thought it was in my bag. I guess it must have slipped out when I was going, at my house. I was. I don't know. Oh, you know what? I think I forgot. I think I was doing that last semester. Next time I come, I'm just gonna leave it here. You're right. Good thinking.
But the spine does, right? Because it does.
That. I mean, well, I'll put it on the card. I'll put it in the card. Yeah, I'll put it on the bottom card. It'll be good.
So,
say it again.
But it's
Or you wouldn't ask us like
The way to absorb is
Together.
absorption.
I'm talking on your phone right now.
So,
If you
ability,
can pop it
the
up
thing that
somewhere.
absorbs is the absorption, right? And the one that goes through is transmission.
Yes, correct.
And what's the third one? Sorry,
Scatter.
scatter is what really doesn't go straight and goes haywire.
Correct.
So like basically the lungs are don't. The lungs
Yeah, no, that's not
they breathe.
But it's on there now.
Right.
They don't absorb. So if it does absorb, like the spine does, that means it has a great rate.
So on this image, if it's like, okay, which areas are dense on this image, right? Which areas receive the most X-rays, right?
The darker you want.
The dark areas receive the most X-rays, right? So out here on the sides, this is where the IR received the most X-rays. Right here in the lungs, this is also where the IR received the most X-rays, right? So that is our radiographic density, right? Our radiographic density here, right? How many X-rays reached the IR. Right? But why were the X-rays allowed to reach the IR? Because the air in front here did a very poor job blocking the X-rays. So air causes that area of the image to have increased density because the X-rays hit the IR. But why is that so? It's because air is radiolucent, which means it has low radio density.
It's the opposite.
So radio density and radiographic density are opposites. So usually, when I talk, I am going to be referring to the tissue itself. So I'm going to be referring to radio density. Right? So fluid is more radio dense, it's more dense than air is. But fluid is less radio dense than bone or metal. So, for example, when we are talking about pleural effusion, no, wait, what were we talking about? We were talking about pulmonary edema, right? And we're saying, okay, there's fluid buildup here in the lungs. I'm referring to, okay, so there's fluid, so that fluid is more radio dense than the air. It's going to absorb X-rays more. Right? So the image is going to turn out whiter. Right? That area is now going to look less dense. It's going to, radiographically on the picture, it looks less dense because the fluid ate up all the X-rays. We're not getting as many X-rays reaching the IR. Okay? But I'm primarily concerned with radio density. So fluid is more radio dense than air, which makes the image look white. We don't want the image to look too white. We don't want all the X-rays to get eaten up. So what do we need to do with our energies, with our exposure factors, the KVP and mass, to make sure enough X-rays get to the IR? Correct. We need to increase the number of X-rays or increase their power. Did you have a question, Shibli?
So, radio opaque things, they always absorb the thing.
Yes, radio opaque items absorb X-rays.
And they look white or what?
And they look white on the image. So, if you've ever X-rayed a patient wearing a shield, and the shield ends up in the X-ray, that area will look super, super white because lead is very radio opaque. It's great at absorbing X-rays. All right, so why does pulmonary edema occur? Usually due to poor pulmonary circulation, right? Due to CHF or CAD. Any idea what CHF stands for?
Congestive heart failure.
Great, congestive heart failure. How about CAD?
Cardiac and autoimmune disease? No?
Coronary
Artery disease.
artery disease, very good. So congestive heart failure or coronary artery disease. Now, because this is not outside the lungs, this is inside the lungs, inside the vessels, right? You see this as an increase in density throughout the lungs, especially in the hilar regions, right? Because hilar region is really dense, it's really filled with vessels. Lots of vessels in that hilar region. Okay, so you take a look here in the center, right? Hilar region. See how it's a lot brighter than you're used to? Okay, that's because of all the fluid in that region. They also show up as increased air fluid levels. Once again, because we do have fluid here, you may see some air fluid levels. So are we okay with pulmonary edema here? Some other examples of pulmonary edema. Okay, once again, you can see how white this hilar region has become. Right? Over here, it seems like the right side is slightly more affected because it is a bit more radiodense, right? It's a bit lighter compared to the left side. By the way, what is this artifact? Yes, this is a pacemaker. Very good. So you've got the pacemaker here. You can usually see the bulge outside the patient, and then you have the pacer wire which goes all the way down to the heart.
So the pacemaker you put on the lung, it's on the lungs.
No, it's not on the lungs. No, it's
The
just
flesh.
It's underneath the patient's skin, and then there's a wire that goes towards the heart.
So if you take like a lateral view, it would be on the front.
Correct. So if you were to do a lateral view, let me see if I can find lateral somewhere. Wow, these are all PAs. Okay, so if you have a lateral view, you would actually see the pacemaker right here. Right, so it would actually be outside of the ribs, outside of the sternum. And you'll see it right here underneath the skin. Right, over here on this side, okay. Once again, pulmonary edema. Which lung is most affected right now? Right, the one where my hand's pointing. Okay, which lung is this? Right lung. Is this the right lung?
It looks like a little L up there somewhere in the right.
Okay.
Where does it say that?
What does it say up here? It says DER PORT SUPINO.
Supine.
Derecho. Right? Derecho.
He's so funny.
What is derecho? Right, very good, right? It's not izquierda, it's derecho.
So what is now is that? Right?
So, right, so this is, so yes, this is in Spanish, right? This was not taken here. Supino. Is that how you supine? Is that how you say? I assume port still stands for portable. I don't know, portable? Okay, so this is a portable supine X-ray. This is the right side.
And left
Spanish
foot,
annotations.
what would left feet? The right and left would be
Izquierda.
K
Izquierda.
S C
I.
Izquierda ISC.
I don't know how to spell it. I didn't know how to
So
spell
how
it.
is right?
Jay will help you. Jay will help you. What's the help?
So
It's good to learn.
Okay.
I. Or Z.
So,
I see.
pulmonary emboli. What is an embolus? Clot.
I see.
Great. What does that mean? To get you what? Yes, emboli can cause strokes. So you have a clot. It could be like a physical clot, or it could be a pocket of air, an air bubble that gets caught in a vessel. If that vessel is up towards the brain, it can cause a stroke because it will keep blood and oxygen from reaching the brain. But if this happens, by the heart, right, where the blood is trying to go from the heart to the lungs, now you have a big problem because you're restricting the amount of blood that can go in and do the oxygen exchange to get rid of carbon dioxide and to get fresh oxygen. Okay. So embolus, any object carried by the bloodstream which can block a vessel. It could be a physical clot, like I said, or it could just be a bubble of air. Pulmonary embolus catches in the pulmonary arterial system. So, pulmonary arterial system, is this before the blood reaches the lungs or after the blood leaves the lungs?
Pulmonary artery is when there's a bad blood going in the lungs. Without let's not say bad word, deoxygenated blood.
Deoxygenated, okay. So pulmonary arterial.
These are the only arteries that carry opposites, veins, what the veins do.
All right, let's keep that in mind. So the question was, does this happen, right? So we say it catches in the pulmonary arterial system. Is this occurring before blood reaches the lungs or after the blood leaves the lungs? Right, so the real question is, what is the definition of an artery?
Blood
Let's see, blood carries away, Jay.
Right here. Blood carries away.
Away from what?
The heart.
The heart, right? That is the key. Arteries go away from the heart. In this case, what is happening is blood comes from the rest of the body through the veins, and it enters the heart in the right atrium. Right atrium pumps that blood down to the right ventricle, and from there, that right ventricle pumps the blood towards the lungs. So now the blood is leaving the heart, correct? Which means the vessel it travels in as it leaves the heart is considered to be an artery. Very good. But this blood came from the veins, right? So does this blood have oxygen in it?
No.
So the blood came from the veins. What kind of blood do we find in the veins? Is this blood with a lot of oxygen or blood with very little oxygen?
The oxygen.
Very little, right? It was right. Normally, veins are carrying deoxygenated blood. They're carrying waste products from all over the body back up to the lungs so that we can expel the waste like carbon dioxide and bring in fresh oxygen. So even though this is an artery, it is still carrying deoxygenated blood, just like Shaheen said earlier. Once that blood reaches the lungs, we have our gas exchange. Carbon dioxide leaves, oxygen comes in, it comes back into the heart through the pulmonary veins, enters the left atrium, left ventricle, gets pumped out into the aorta, and from there it goes into the rest of the arteries. The problem here is we are blocking the point where blood goes from the heart to the lungs. Now, we are looking at a vessel, a very small vessel comparatively. And we're looking for a clot, which isn't usually very visible. So it's really, really, really hard to see pulmonary emboli on X-ray, right? Supposedly there's a pulmonary embolus here. I've tried looking for it before, I still don't see it. So, what do we use instead of X-ray? We normally use CT. So, this is what a CT scan looks like. And you're only seeing a very small section of the chest right now. Basically, we are only looking at a picture of this section of the chest, this very thin section, right? We can't see anything below it, we can't see anything above it. We're only looking at this very, very thin slice here. But if you take a look here, this part where it's bright, this is fluid, this is blood. But as the fluid comes this way, suddenly you see this appear out of nowhere to kind of block the fluid. That is our embolus. That's our emboli. Over here, same thing. We've got our heart here, we've got vessels here, and if you look inside the vessels, some of them have this dark spot. So you see that, so you're looking at the vessel like this, right? Blood's flowing this way. So normally the whole thing should be bright because the whole thing is full of blood. but there's this giant dark spot in the middle. Why? Because there's an obstruction sitting right in the middle of the vessel that is keeping blood from traveling through it.
You said that's just a clot, right?
Correct, that is a clot. So because this clot is showing up black, it's most likely going to be just some sort of air bubble that got caught here. Or it could be maybe but it also could be something like caused by platelets, like there was a clot somewhere in the system, the platelets broke off, and then they got stuck inside the vessel. So that is a pulmonary embolus. Once again, very, very hard to see on X-ray. Yes, Charles.
So just to confirm, you're saying that it happened before it enters the organ?
Correct. This happens before it enters the
Just want to make sure you
Respiratory distress syndrome. So, respiratory distress syndrome can affect both infants and adults. Okay, so this can affect both groups. But when it affects infants, it has a different name. For infants, this is called hyaline membrane disorder. Hyaline membrane disorder. So because this does affect the lungs, once again, we view this on PA lateral chest X-rays. The idea here is that in the lungs, we have the air sacs, which are the alveoli, correct? And those air sacs will kind of like expand and contract based on air as air comes in and out of the lung. However, alveoli are only able to do this thanks to a kind of almost like a lubricating fluid. Okay, that's probably the best way for me to describe it. There's like this lubricating fluid called surfactant. Surfactant is what allows the alveoli to perform normally. If there is a lack of surfactant, the alveoli will not be able to expand. They will instead collapse. So, in some infants, they lack surfactant, or they do not have enough surfactant. And so the alveoli collapse, and now the baby is unable to breathe properly. Okay, so respiratory distress syndrome, infants known as hyaline membrane disorder. Now, in adults, it's not due to a lack of surfactant. Right? Because if it suddenly occurs, it's not because the surfactant suddenly turned off. Usually what happens here is that we have pressure outside the alveoli, which pushes it inward and forces it to collapse. Okay, almost like a pneumothorax. But instead of air outside, we are having fluid or blood. So there's fluid or blood outside the alveoli, in between the alveoli, and that pressure collapses the alveoli, and once again, they cannot expand to take in oxygen. Okay, so respiratory distress syndrome. Granular pattern. So granular pattern, it looks like grains. Think like grains of sand. It looks sandy. Okay. It looks spotty. Right? So if you take a look here, you see how you've got this grainy, fuzzy, dotted look. Right? It's not like right? So it's not like this, where it's kind of like lines and splotches, right? This is much more fine, right? It's dotted. That is that granular pattern. And then, because right, this is going to be, yes, we've got like fluid here, right? Fluid is going to be more radiodense, so you would need to slightly increase your energies, your kVp or your mass, to properly image the pathology. in addition, because the lungs are going to show up much whiter now, right? You've got all these white, grain-looking splotches. Any air that exists will show up much more clearly. So we may see something called an air bronchogram. So let me show you what an air bronchogram looks like. All right. So once again, baby, right? Lungs do not have air inside them, right? Because those alveoli were not able to expand to take in the air. So it looks really white, correct? However, if you take a look right here down the middle, do you see this? You see this pretty clearly, right? Trachea into the bronchi, right?
Oh, yeah.
What's the split here called? Carina, very good. So because everything lacks air except the trachea and bronchi, they show up so much more clearly. So this is what we call an air bronchogram, right? Gram, right? A picture of broncho, the bronchi, air because of the air inside, right? The air causes the bronchi to show up nice and clear because its background is basically fluid. Does that make sense? That's a great question. I'm not actually sure how they're able to treat it. I don't know if there's some way for them to like force the body to jumpstart surfactant production while maybe like using pressure to force air into the lungs, force the alveoli to expand. I'm not sure. We're not sure how they treat this. Something good to look into maybe. Maybe something for your, if you want to do the research project next summer, maybe a possible topic to look into.
That one's not mandatory, right?
So no, the research is not mandatory. But, you know, if you do win the research competition, there's some cold hard cash waiting for you.
I think $50.
Tuition paid for?
No, 50 for third place.
Okay.
What about first?
I believe
Huh?
first, I think it's 150. I think it's 150. But you've also, you can use your research to enter multiple competitions because you've got the paper, you have the oral presentation, you have the poster presentation, right? So, you know, that's 450 right there. Okay, just saying. Something to keep in mind, something to think about. Over here, right, same thing. Okay, so lungs, as you can see, are not inflated. You look here, you can see the trachea, you can see the bronchi.
Which one is the trachea?
Trachea is right down here, and then bronchi come off right
So it's the pretty black. I don't see
here. Right, bronchi, trachea.
also white crystal, doesn't have the
So maybe this one might not be as clear. You might need to train your eyes to look for that one.
Wait, why did you underline
Now, if this happens in an adult, right, it's no longer hyaline membrane disease? Yes, hyaline membrane disease. This is RDS, just regular respiratory distress syndrome, or ARDS, adult respiratory distress syndrome. So as you can see, right, once again, you've got these fluid-filled areas, right? That's going to be the fluid surrounding the alveoli. Okay. Same thing on this side as well. So something like this can cause dyspnea, for example. What is dyspnea? Shortness of breath, difficulty breathing. Very good. Difficulty breathing. Yes, so it might be tough to see, but do you see this tube right here? Right, so it starts kind of like up here, and it goes right down and ends right here. There's the tip of the tube. And then just a bit lower, you have the carina right here. Are you able to see that? Kind of? So, so, what is that?
Got an assistant today.
Yes. So this is outside the body. So yes, this tube here is inside the trachea. This tube here is outside the body, leading towards the mouth. This here is a breathing tube. So a lot of times, if a patient needs to be intubated, if they need a breathing tube basically stuck down their throat, they will take this tube, put it down the trachea, leave it about 1 to 2 inches away from the carina, and then call in X-ray to make sure they have the breathing tube in the correct location, right? That they haven't accidentally stuck it down the esophagus, or they haven't pushed it too far and they're only inflating one lung, right? So this is something that you'll be helping them look for. Okay. All right, let's finish up real quick here. Yes.
Sir, the infant one is called hyaline membrane disorder, but in the adults it's called the respiratory distress syndrome.
Okay. Yeah.
So is that the name of only the difference in name, or is the condition difference?
Same condition.
Same.
Same condition. Okay. So, real quick, pneumoconiosis. Right? Pneumo, once again, dealing with air, dealing with the lungs. Coniosis, now we're dealing with dust. All sorts of dust. So, 3 main types of dust we are going to discuss. Anthracosis, coal dust. Asbestosis, asbestos. And silicosis, silicon dust. Anthracosis, also known as black lung disease or coal miner's disease. Okay, so people that work in coal mines, they're constantly breathing in the dust from the coal mines, and that dust enters the lung, deposits in the lungs, doesn't come back out, and it causes damage to the lungs.
So always stay there for
Yes. Yeah, I do not believe you can get it out. So, you look here, right, you can see kind of like the scarring caused by that coal dust. Asbestosis. So asbestos, kind of like fibery dust. Okay. So asbestos is carcinogenic. It can cause cancer. Breathe it into the lungs, it can cause lung cancer. Okay. So here, once again, you can see kind of like that scarring, that extra opacity, the extra brightness caused by the dust. Right, so it used to be used in like construction, I think used, I'm not sure if it was like insulation. Okay, yes, used for insulation. So yes, asbestos is not something that we want to be interacting with without precautions.
in Spanish.
That's the commercial, right?
Yeah.
Oh, like if you've ever been.
Yeah, when they
asbestos,
that's what they were talking about.
The commercial?
Yeah, commercial.
That's how I know what it is for the commercial.
Right, so here, right, you can kind of see the scarring, you can see the damage, right? Almost like calcifications of the lung. Finally, silicosis. This is caused by silica or quartz dust, which is also often released in mining. Increases the chance of this patient developing tuberculosis, seen as nodules and scarring in the lungs. So I think of a really nice picture in the next slide. There we go.
Oh.
Right, see these nodules? Right. See those dots? Right, so that is caused by silicosis, silicon dust. from life. And that concludes this chapter.
Second last.
So this is pneumoconiosis or pseudoconiosis.
Does that mean if you get it 3 times, it increases your chance of TB?
No, it means that if you do get this, your chance of getting TB are 3 times higher.
Oh.
Asbestosis, silicosis, and what was the third one?
Asbestos.
You don't remember getting TB, but you did as a child.
Silicosis,
Well, yeah, you can't really remember things when you're 2. That childhood amnesia.
There's the anthracite one.
Oh, wow.
The black lung, coal miner's lung.
There's like 26 of them. I think he's gonna test on us, every single one of them.
There's so many of them.
All the
Well, now that you know better,
diseases,
right?
you know. There's like 26 of them.
26,
So,
yeah.
So I guess we had to study every single one. Just
You'll be judgy.
He says we're going to be tested on?
Where's my
But,
shield?
I mean, I know it's on an exam.
Yeah.
But what did he
I mean,
say?
on the exam, like
Oh, yeah, yeah.
every single one we would
Yeah,
try.
yeah. Is it going to be all on the first exam? What did he
Yeah.
put on his
Where's the-
PowerPoint?
where are my dressing
Because
instructions?
Yeah, I
he
guess
had
so.
2 different, one for PRE and one for this one.
Yeah. It's
But
a lot.
pneumoconiosis has 3 types, right? Asbestosis, silicosis,
I thought he was saying that because I thought he was going to make me do something. That's
and
what
what is the dark
Black lung disease.
Black.
What is asbestosis?
It's from building.
You have the PowerPoint slides, correct?
Yes.
No, the drawing, the
Oh,
little drawing.
the drawing. Oh, okay, okay.
Are you from the draw?
Just making sure that you all have that PowerPoint. Okay, so for next class, we are actually going to go into abdomen as well, right? Chest and abdomen are being combined for the exam. So next week we're going to be going into abdomen pathology, which means I have another one of these worksheets for you. This one is a little bit shorter.
You showing out this
So
semester.
it should not be. It should not take as much time
It's
as your
little,
last
so
one. We do not have as many pathologies for the abdomen.
thank you.